if that's okay. Welcome everyone to Geriatric Medicine Grand Rounds. Happy Friday. Glad you all could join us. We have a fantastic invited guest speaker today that I'll tell you about in a moment. If you have questions during the session today, feel free to put them in the chat and we can go through them at the end of the talk. And we'll just go ahead and get started. So Dr. Ariel Green, many of you might have heard her speak at AGS meetings and read her work. We're really excited to have you. She is an associate professor at Johns Hopkins University. She's a geriatrician and general internist. She did much of her training, or maybe all of her training at Johns Hopkins. That's where she got her medical degree and her master's in public health and her PhD, as well as her residency and geriatric medicine fellowship. And she's now on faculty there. And her area of research focus, which is funded by the National Institute of Aging, really focuses on evaluating the impact of interventions to optimize prescribing for older adults, particularly those with dementia in primary care. And she's been involved at the national level in many efforts to improve prescribing for older adults. She was involved in authoring the Choosing Wisely guidelines that the American Geriatrics Society produced, and has done lots of things that I could spend much time talking about. And we're very appreciative for all the things you've done to move forward the care of older adults in this country and around the world. So thank you so much for taking the time out of your very busy schedule to talk to us today. And we're really excited to hear what you have to say.
Thank you so much for that introduction. It's really my privilege and an honor to be here. Let me share my screen. All right. So can you all see that?
Yes.
Great. Thank you. So as I mentioned, I'm really excited and honored to be here speaking with you today and to have the opportunity to tell you about my research, which focuses on aligning medications with what matters most. I have no disclosures. And so just to give you an overview of what I'll be talking about today, I'm going to identify de-prescribing. Oh, sorry, there we go. Okay. I'm going to identify de-prescribing as a promising strategy to improve care for older adults with multiple chronic conditions, including dementia. I'll describe the results of our research to assess patient-preferred language to achieve goal-aligned de-prescribing. And finally, I'll discuss how these results are influencing the design of de-prescribing interventions, specifically for people living with dementia in the primary care setting. And so I always like to start my research presentations with the story of a real patient. So this is Ms. R, who's a 93-year-old retired crossing guard who came to see my colleague, Dr. Stephanie Nothel, in our geriatrics clinic at Hopkins. She has a history of dementia, chronic obstructive pulmonary disease, diabetes, low back pain, anxiety, and recurrent falls. And at her first visit, she came in a wheelchair accompanied by family, and she was unable to answer questions or to stand without assistance. And her mini mental state exam score on that day was 13 out of 30. Her concerns, and really her caregiver's concerns, were her excessive fatigue, recurrent injurious falls, forgetfulness, and polypharmacy. And their goals were to optimize her quality of life, to have her take fewer medications, and to be able to remain safely in her home for as long as possible. So this is a list of Ms. R's daily medications, and as geriatricians, we see lists like this all the time. And so she's taking 12 medicines. She has a complicated regimen that involves taking medicines of different formulations and routes at various times of day. She's taking multiple medicines that are either high risk, such as insulin, or associated with increased risk of falls or cognitive adverse effects. Those are the ones I've highlighted in red. There's evidence of prescribing cascades, and it's possible that several of her medicines are no longer aligned with her goals of care. And so the question that really motivates my research is, how can we do better for patients like Ms. R? And so Ms. R is experiencing polypharmacy, which has been called the unintended consequence of good healthcare. And that's because all of her clinicians are doing their best to prescribe medications to treat her chronic conditions and to follow clinical practice guidelines for each of those conditions. But as we all know, that can sometimes have unintended consequences. And so this table is the result of landmark work by my primary mentor, Dr. Cynthia Boyd at Hopkins. And Dr. Boyd and colleagues created a hypothetical older adult patient with five common chronic conditions of moderate severity. And they looked at the clinical practice guidelines for each of those conditions. And this table is what would result. So on the left-hand side, what would result from following each of those guidelines. And so on the left-hand side of the table, you can see all of the medications that this hypothetical patient would have to take throughout the day and at various times. And then the middle two columns, you can see other non-pharmacologic recommendations they would be asked to follow. So things like checking their feet, checking their blood sugar, staying upright for half an hour after taking their bisphosphonate, following a special diet. And then in the far right column, you can see other periodic monitoring they would have to do as a result of those medications. So blood tests to monitor for adverse effects, referrals to specialists, DEXA scans, yearly eye exams. And so this is a lot to fit on a slide, let alone as a patient and their family to follow all of these recommendations creates a lot of treatment burden and can be quite overwhelming. And these guidelines come from the best available evidence from large randomized trials in many cases, but how well does that evidence really apply to patients like Ms. R, who are older and have multiple chronic conditions? And so we know that the enrollment of older patients in clinical trials is still well below their share of the affected population. And beyond inclusion-exclusion criteria, really those are less important than who the average patient in a trial is. And the average patient is rarely someone like Ms. R. The good news is that with the NIH inclusion across the lifespan policy, the number of trials with explicit age exclusions is going down and the trial enrollment of older patients is increasing. And so clearly we need promising strategies to improve care for people with multiple chronic conditions like Ms. R. And one such strategy is medication stewardship or optimal prescribing. And so just as we have antibiotic stewardship, where we try to reduce unnecessary antibiotic prescriptions and prevent iatrogenic harm, the same should really be true of all of a patient's medications. And so medication stewardship is a more thoughtful approach to prescribing that's based on the best available evidence of benefits of a given medication outweighing the risk of harms. It should be goal aligned, not primarily guideline driven. It should occur in the context of other non-pharmacologic therapies, such as physical therapy or mental health counseling. It should involve ongoing monitoring and reevaluation to make sure that each medication is still indicated and still truly helping the patient. It should involve patients and care partners in shared decision-making about medications, and it often involves de-prescribing, which, as many of you know, is the structured, supervised process of withdrawal, dose reduction, or substitution of an inappropriate medication with the goal of improving health outcomes and quality of life. And an inappropriate medicine is one that is high risk, low likelihood of benefit, unnecessary, or no longer aligned with the patient's or care partner's goals. And so next I'm going to shift gears a little bit after that background and tell you about our research to assess patient preferred language to achieve goal-aligned de-prescribing. And the reason we chose to focus on the language of de-prescribing is that we know that patients who are engaged in decision-making tend to choose more conservative treatments and receive less unwanted care, including fewer unnecessary medicines. We also know that patient-centered care, including patient-centered communication, is linked to higher patient satisfaction and quality of life, and that patients and care partners currently may not recognize the potential harms of medications, or that medications often carry trade-offs. So for example, there was some qualitative research by Kearns and colleagues that found that caregivers of patients with dementia who were receiving antipsychotics for behavioral symptoms were unaware that those medications had considerable potential for serious adverse effects, even though they have a black box warning, and that's well known among geriatricians. We also know from work by Emily Reeve that across cultures and countries in national surveys, patients want to de-prescribe if their doctor recommends it. So when asked the question, if your doctor recommended stopping a medicine, would you be willing to? That receives patients have high levels of agreement with that across the board. And so we did 2 qualitative studies to gain insights on de-prescribing communication. And so the first one was an observational study in which we had the opportunity to listen in on 93 audio recorded primary care encounters of older adults with cognitive impairment, their care partners and clinicians, to understand what language and phrases were being used during de-prescribing conversations. And the second was an in-depth, was a study based on in-depth individual interviews with 49 older adults with cognitive impairment, their care partners, and primary clinicians in the optimized de-prescribing trial, which I'll tell you more about in a few minutes. And in that study, we wanted to understand what key phrases and rationales resonated with patients and care partners around de-prescribing. And so for the sake of time, I'm just going to highlight a few of the key messages, the key themes that we learned from these qualitative studies. And so the first key theme was the importance of establishing a partnership with the patient and care partner and respecting their lived experience before initiating a de-prescribing conversation. And so this is a quote that highlights the way that one primary care clinician did just that. And so they said, I want to get to know you and then work together on minimizing your medicines, understanding that I need to take care of your neuropathy and make sure you're sleeping well. So I won't sacrifice what needs to be done, but I will try to minimize the amount of medicines. The next key theme that we identified was the importance of framing de-prescribing as a positive action to improve well-being and quality of life, not a withdrawal of care. And so the first quote is from a care partner that exemplifies what care partners may hear if de-prescribing is not framed as a positive. And so this care partner said that she heard what she understood the doctor to be saying was, at your age, you've probably lived a good long life. And she said, I didn't like that because I would like to preserve my mom forever. And the next quote is from a primary care clinician who was trying to frame de-prescribing as a positive. And so they said to the patient, these medications can take years or decades to have an effect. And I think that we should focus on what can help you right now. Finally, another key theme that we identified was the importance of aligning de-prescribing with what matters most. And so the first quote is from a primary care clinician who tried to do that by asking, what would make you feel better and more independent? And then the second quote is from a care partner who said that she had learned over the years of caring for her father who had advanced dementia to ask the question of the doctor, what medications do they really need? If it's not going to make things better, then I don't want him to have that medicine. And so next, we wanted to take some of these key phrases and rationales that we had identified in the qualitative research and test them on a larger scale in a national survey. And so the goal of this survey was to determine how older adults want clinicians to talk to them about de-prescribing. This was a cross-sectional survey using the nationally representative Ipsos Knowledge Panel, which is an online survey panel. And we received responses from 835 people 65 and older, which was a 70% response rate. And we had 2 modules in the survey. The first concerned a preventive medicine, which was a statin being taken for primary prevention of cardiovascular disease. And the second module focused on a symptom relief medicine, or Zolpidem, being taken for insomnia. And so in the first module, we described a hypothetical patient. This was the statin module. We described a hypothetical patient with multiple serious health problems who required continuous oxygen, serious functional impairment, requiring help from her caregiver with activities of daily living, and polypharmacy. She was taking 10 medicines per day. And that's because the benefits and risks of primary prevention statins in patients such as patients like that are really, there's a lot of uncertainty. The second module concerning the Zolpidem described a patient who was in good health and functional status, taking 6 pills per day. And respondents were asked to pick the explanation that was most and least likely to make them stop the medicine. And it's important to point out that the hypothetical scenarios described a situation in which they had a long-standing trusting relationship with their primary care provider, and that the provider was making the de-prescribing recommendation based on their understanding of the patient's priorities and what was best for their health. And so for each hypothetical and each module, we tested 7 phrases a doctor may use to suggest de-prescribing. And we used the best worst scaling method, which is thought to reduce the cognitive load on respondents by asking them to compare just a few phrases at a time rather than the whole list. And the survey phrases, as I mentioned, were taken in part from our qualitative research, and the survey phrases and hypothetical scenarios were refined based on stakeholder feedback. So we piloted the survey with different groups of older adults. And so just briefly, these are the demographics and clinical characteristics of the survey respondents. So the average age was 73, about half were women, 20% were of non-white race or ethnicity, 36% had a high school education or less. The number of daily medications being taken by the respondents was on the low side at 4. 17% reported that their overall health was fair or poor. 59% had ever taken a statin, and 15% had ever taken a sleeping pill. And so first of all, for the statin module, these were the phrases that we asked respondents to consider. The benefits of this medicine do not clearly outweigh the harms for people like you. I do not feel that you need this medicine anymore. Given your age and other health problems, I do not think this medicine will help you. Given your age and other health problems, I'm worried that you're at increased risk of side effects from this medicine. Taking this medicine requires extra effort for you. It's another pill to swallow, costs you money, and requires periodic blood tests. I think it could be harmful for you to be on this many medicines. And finally, I think we should focus on how you feel now rather than worrying about things that may happen years down the road. And these are our primary results for the statin module. And so these are the phrases ranked from most preferred on top to least preferred on the bottom. And on the x-axis is the number of times each phrase was chosen as most preferred. And so each phrase was presented multiple times. And so the total number of times that a phrase could be chosen by all respondents was about 2,500. And so you can see that, first of all, there's a lot of variability in responses. So phrases that were chosen as most preferred were also a fair number of times chosen as least preferred. But overall, the most preferred phrases were the ones dealing with increased risk of side effects or a harmful overall number of medications or the benefits not outweighing the harm. So phrases that dealt with potential risks of the medicine. And for the statin module, the least preferred phrases were the ones dealing with extra effort or treatment burden required in taking the medicine, and the one that said we should focus on how you feel now rather than things that may happen years down the road. So next I'll tell you about the results for the Zolpidem module, and then I'll talk about some of the implications of these findings. And so these were the phrases that we tested for the Zolpidem module. So first of all, I'm worried that this medicine may cause you more harm than good. Medical guidelines recommend that we avoid prescribing this medicine for sleeping problems in older adults. Over the long run, this medicine is unlikely to help you function better. This medicine has been linked to side effects such as problems with memory, concentration, balance and falls, hospitalizations, and death in older adults. People can become dependent on this medicine, meaning they can't fall asleep without it. We can treat this condition without medicine. It will take time and effort, but you can learn to fall asleep on your own. And finally, this medicine is not good for you in the long run. Let's work together to slowly reduce the dose and get you off it over time. And so these were our key results for the Zolpidem module. And so again, you can see that the most preferred phrases were the most preferred phrase was the one dealing with the increased risk of side effects. The second most preferred phrase was the one that says, let's work together to reduce the dose and gradually get you off it over time. And then the third most preferred phrase was another one dealing with the risks outweighing the benefits. They're more harm than good. The least preferred phrase was the one that said, this medicine is unlikely to help you function better in the long run. And the second least preferred phrase was the one about addressing insomnia with non-pharmacologic methods. And so the conclusions and implications are, first of all, that a major driver of willingness to de-prescribe for both medication classes was the risk of side effects. We also learned that for the symptom relief medicine Zolpidem, participants preferred a phrase that emphasized that this was a shared decision and it would occur gradually over time. We learned that some patients may prioritize symptom relief over function, which surprised us. The phrase, over the long run, this medicine is unlikely to help you function better, because as geriatricians, we always think that that is the major priority of many patients. We also, another finding was that some may interpret the phrase, we should focus on how you feel now versus things that might happen years down the road. We thought that some may have interpreted that phrase as suggesting that they no longer warrant prevention. And so that's why that phrase did not resonate with patients for the statin module. And then finally, we found considerable variability in preferences, which just underlies the importance of getting to know the patient and understand their priorities before initiating a conversation about de-prescribing. And so we wanted to, based on those results, we wanted to learn more about patients' overall health outcome priorities related to medicines and how that may impact their willingness to consider de-prescribing. And so using the same survey, we wanted to address the question of whether willingness to de-prescribe is associated with overall health outcome priorities related to medicines. And this is the rationale for this is because one approach to eliciting preferences for patients with multiple chronic conditions is to have them prioritize outcomes that apply across diseases. So universal health outcome priorities, things like physical and cognitive function and living longer. But little is known about whether willingness to de-prescribe is associated with those universal health outcome priorities. And so the outcome in these analyses, there were two separate analyses. One was the willingness to stop a preventive medicine. One outcome was the willingness to stop a preventive medicine. And then the second analysis, the outcome was the willingness to stop Zolpidem, or a symptom relief medicine. And the major predictors were the respondents' agreement with two universal health outcome priorities statements. So they were asked, on a scale of 1 to 5, how strongly do you agree or disagree with the following statements? One was, I'm willing to accept the risk of future side effects, such as falls or memory problems, to feel better now. And that statement was tested in the Zolpidem model. And the second predictor statement was, I would prefer to take fewer medicines, even if it meant that I may not live as long or may have bothersome symptoms some of the time. And that was tested in both the Zolpidem and statin models. And so these are some of our results. So first of all, we found that there was, as in the Emily Reeve studies, there was high willingness to stop medications with slightly higher willingness to stop preventive medicines. So 61% said they were willing in general to stop a preventive medicine, such as a statin, if their doctor recommended it. 50% said they were willing to stop a symptom relief medicine, such as Zolpidem. 59% said that they would prefer to, or they prioritized avoiding future side effects over feeling better now. And 36% said that they would prefer to, or they would prioritize taking fewer medicines over not living as long or having bothersome symptoms some of the time. And so our major results from this study were, first of all, that respondents who prioritized avoiding future side effects over feeling better now did have higher odds of being willing to stop symptom relief medicines. And you can see the adjusted odds ratio there. And then the respondents who prioritized taking fewer medicines versus living longer or avoiding bothersome symptoms sometimes had higher odds of being willing to stop both medication classes, the symptom relief medicine and the preventive medicine. And so the implications of this are that older adults' health outcome priorities based on this national survey do seem to be related to their willingness to consider de-prescribing. And so the next step in our research was to determine how to best elicit those universal health outcome priorities related to medication use and use them to facilitate goal concordant decisions about medication use. And so next, I'm going to tell you about some of our team's research to test system-wide approaches to foster goal-aligned de-prescribing in primary care. And so both of the studies I'm going to tell you about focus on people living with dementia. And that's because, as many of you know, people with dementia tend to use more medications and have more complex medication regimens than people without dementia. And medication regimen complexity is associated with adverse drug events, poor adherence, hospital discharge to non-community settings, and hospital readmission. And it's also a major source of burden for care partners. We also know that health systems rarely identify or support care partners or collect data on outcomes that reflect their lived experience. And so that was something that was also important to us, particularly in the second study that I'm going to tell you about. And so first, I'm going to tell you about the Optimize de-prescribing intervention. So the co-PIs of this study are Dr. Liz Bayless at Kaiser Permanente Colorado's Institute for Health Research and Dr. Cynthia Boyd at Hopkins. And I had the great opportunity to be a co-investigator on this trial. So the target population for Optimize was patients with dementia and 5 or more medications who had an upcoming primary care visit. Optimize was designed with heavy involvement from patients, family caregivers, and primary care clinicians. And it was designed as an educational, low-intensity intervention to increase awareness for patients and providers about de-prescribing. It was also designed to be fully pragmatic with no change in workflow for the clinic and clinic staff, and no medication management by the research staff. It was piloted at one KP Colorado clinic in 2018, and a full cluster randomized trial occurred in 18 KP Colorado clinics in 2019 through 2021, so right during the pandemic. And the primary outcomes were the total number of medicines and the percentage of patients taking one or more potentially inappropriate medicine, defined using the Beers list, at 6 months. So these were the educational, or some examples, I should say, of the educational materials that were the foundation of the Optimize intervention. And these were designed really largely drawing from our research on patient preferences for de-prescribing communication. And so in Optimize, the primary care providers received 12 monthly one-page tip sheets about de-prescribing. And each tip sheet focused on a different aspect of de-prescribing, such as a different medication class or clinical scenario. And we really focused in those tip sheets on the language of de-prescribing. So on the left-hand side, you can see one of those tip sheets, and it includes the phrase. So each tip sheet included key language that providers could sort of keep in their back pocket and use during de-prescribing communication. And so this one includes the phrase, de-prescribing is normal. De-prescribing is a normal part of high quality care. And it also attempts to elicit whether the or what the patient's overall goals of care are related to medicines. And so it suggests asking what sorts of activities and events are most important to you these days. On the right-hand side, you can see part of the brochure that was mailed to patients and their families ahead of a routine primary care visit. And this also is designed to empower them to talk with the doctor or with their clinician about de-prescribing. And it also uses phrases and rationales that we learned from our qualitative research, such as many people feel better when they take fewer medicines, and there may be ways to treat your health problems without medicine. And so just briefly, some of the key learnings from the optimized trial, these results were just published recently. And some of the key learnings were that this large-scale pragmatic de-prescribing intervention was delivered safely. So we did not see an increase in adverse drug withdrawal events in the intervention versus control group. We also found that there were small effect sizes and for each of the primary outcomes, and they did not reach statistical significance. So this was a negative trial, which may in part reflect the low intensity of the intervention. So the providers received those tip sheets and the patients and families received the brochure just mailed to them once ahead of a primary care visit. And then because this was designed to be so pragmatic, we really just, at that point, hope that those materials would encourage patients and clinicians to start a conversation. In the pre-planned subgroup analyses, we found that there was more of a, statistically significant positive effect in the patients with 7 or more medicines at baseline. And so this suggests that similar low intensity interventions could be effective in populations with higher levels of polypharmacy. And then the key learning that I'm going to focus on in the rest of the talk is that we learned in qualitative research at the end of Optimize that clinicians may need more individualized guidance, tailored to the individual patient, and support to elicit patient and family goals and to align medications with them. Because medication, we were trying to tackle the entire medication regimen, and that is very complex. And so that, and patients and families expressed the desire to really, have more of to be able to talk more about their medicines. And clinicians said, we would love to have that conversation as well, but it's hard when we have 10 other things to do during a primary care visit. And so that led us to develop the ALIGN pilot study, or aligning medications with what matters most. And we were really fortunate to receive funding from the NIA's Impact Collaboratory for a pilot of this intervention, and again, to be able to partner with our colleagues at KP, Colorado's Institute for Health Research. And so ALIGN is designed to leverage the interdisciplinary team and really to leverage the embedded clinical pharmacist within the primary care clinic and the trust that patients and families and clinicians told us they had in those embedded pharmacists. The pharmacist's role in the study is to help elicit the patient and family goals of care and to facilitate shared decision-making around medicines. ALIGN is also designed to explicitly address the care partner's informational and decisional needs around medicines. The intervention is further designed to provide tailored evidence-based guidance to primary care providers, so tailored to the individual patient, and to support patients and care partners on de-prescribing in between visits. And importantly, it does this without adding time pressure to primary care providers. And so I just wanted to briefly highlight the members of the ALIGN team. So I'm leading the study at Hopkins, and then at KP Colorado, the site PI is Dr. Rebecca Boxer, who's the director of clinical trials. And this amazing team is really making this intervention possible. And so this is the design of the ALIGN pilot study. So this is a 3-part intervention. So the first part is patient and care partner education. So the patient and care partner receive a brochure in the mail, similar, I'll show it to you in a minute. It's similar to the brochure in Optimize, but introduces them to the idea of working with a clinical pharmacist who then in turn works closely with their primary care provider. After they receive that brochure, they're scheduled for a pharmacist-led goals alignment telehealth visit. And so the clinical pharmacist conducts this telehealth visit using a template that we worked with our pharmacists to design. And I'll show you an excerpt from that in a minute as well. And once the pharmacist has elicited their overall goals of care, they then come up with de-prescribing recommendations to align the medications with the goals of care. And they then reach out to the PCP using a standardized template in the EMR to offer up to 3 concrete actionable de-prescribing recommendations. And once they have the PCP's approval, they call back the care partner and begin to implement those changes. And so the setting for the Align pilot study was primary care practices at Johns Hopkins Community Physicians, as well as Kaiser Permanente, Colorado. The population was patients with dementia and 5 or more medicines identified from the EMR, as well as their care partners. And we enrolled them as dyads. And the dyads were randomly assigned to either the immediate intervention group or a delayed control group with a goal of 30 dyads per group. And this slide, I won't dwell on this, but this is just to show you that we engaged stakeholders throughout all the phases of Align planning and design, the implementation phase, and now in preparation for a future full randomized trial of Align. Briefly, this is the Align brochure that was mailed to patients and families. So it builds off of the optimized brochure and was refined using what we learned from our qualitative research. It looks a little funky here because it's a trifold brochure. And so this is what it would look like flattened out, but you can see that it's really designed to invite people to work with a clinical pharmacist who works closely with their primary care doctor. This is an excerpt from the goals alignment visit that the pharmacist conducts with the care partner and the patient if they're able. And so this was based on templates that the clinical pharmacists are using for comprehensive medication management visits, but we worked with them to incorporate a focus on dementia and on goals elicitation. And so the template includes questions such as, what are your most important goals for your family member's healthcare for the next 6 months to a year? Some people say they want to do everything they can to prevent future illness, such as heart attacks and strokes, even if it means taking additional medicines or experiencing side effects. Others say they want to focus more on comfort than prevention of things that might happen years down the road. What would you say is more important for your family member right now? And finally, if we changed your family member's medicines, what do you wish we could help with? And so the primary outcomes for the Align pilot study are focused on feasibility and acceptability of the intervention. And so you can see here we have a number of measures related to that. We're also focused on assessing the feasibility of measuring the following primary and secondary outcome measures for the future pragmatic randomized trial, the medication regimen complexity index. So this can be derived entirely from the electronic medical record. So it's pragmatic. And unlike a simple medication count, the idea is that the MRCI goes beyond that to really get more at the burden experienced by patients and care partners. And so it looks at all the different forms of medications a patient is expected to take or different routes, the frequencies of those medicines throughout the day, and any additional instructions, such as whether they're expected to take it with food or at a certain time of day, or to break a tablet or crush it, for example. And then a secondary outcome we're looking at is the Family Caregiver Medication Administration Hassle Scale, which is a mouthful, but that is a care partner reported outcome measure that has several domains designed to assess their experience with helping someone with their medicines and the experience, again, of treatment burden. So stay tuned because we actually just wrapped up our last intervention call this week. So we were able to enroll 30 dyads at KP Colorado and 25 at Hopkins. And we're now just doing our final data collection. And so within the next few months, we should have some results from the pilot study. So with that, I'm going to wrap up. I'm just really honored that you asked me to be here, and it was a pleasure speaking with you. And I would love to take your feedback and any questions. I just wanted to acknowledge again all of the people and the funders who have made this work possible. And I'll stop sharing my screen and happy to take your questions.
Okay, wow, thank you so much. This was great, especially I think like for me talking about the words matter part and giving examples of words that might be helpful. Sometimes we say things thinking that they'll land one way and they go a different way. So really helpful. There's a question here on the chat from Kay asking what sort of training did the pharmacists get on goals, illicit training? Did they get training on how to develop goals which are realistic and actionable? In the knowledge of the patients, the dyad's ability and willingness to do or not do things?
That is a fantastic question. And that's something that, so for the pilot, I would say we had 2 intervention pharmacists, 1 at each site. And we were so lucky that they were very geriatric trained and geriatric focused pharmacists. And so we did that for the pilot. And then now so they already had training in this. And then our hope is that the template would really further help pharmacists who don't have as much of a background in geriatrics and in goals elicitation, would sort of give them the language to do that. But we recognize that for a full trial where we're trying to do this at scale, we would need to have more training. And so we're now talking to the pharmacists as part of our stakeholder engagement, not only the intervention pharmacists from the pilot, but many other clinical pharmacists to try to understand what kind of training would be, how we could deliver that training and what kind of training we could do and still have it be relatively pragmatic.
Okay, thank you. And I see Diane is asking if you can leave the QR code on.
Oh, sorry.
I think you had it there at the end, I think.
Yes.
And that's so that people can like get a link to the evaluation. Thank you. And if anyone has questions, feel free to unmute and speak up. Otherwise, I can also keep reading the chat. And Kay, do you want to unmute or? Okay, I don't know that she can. So she was just commenting again that she agrees that templates help a lot, but would recommend considering additional feedback training on goals development.
Yes, I definitely agree.
Then Dr. Phelan is asking if you hire pharmacists specifically for the study.
So for the pilot, the pharmacist time was actually donated in kind. I mean, it was very much, and we actually, I will say when we designed it, so they were not hired specifically for the study because we tried to align it with work that they're already doing. And so it was very much, they're doing comprehensive medication management calls with patients with certain conditions. And so we're trying to make this so that it kind of fits in with that work.
Again, going in order, but if anyone wants to unmute, feel free. Ruru was asking have you observed, in the pilot phase of the study, if you observed any cultural differences in acceptance of recommendations by patients and families?
Yeah, that's a great question too. So we have not looked at that yet in Align, though I will say that in Optimize, we did, as part of our qualitative research after Optimize, we specifically tried to recruit patients and families who were African-American and Hispanic or Latinx, and tried to ask them about how the materials were received. We did not, as part of Optimize, we did have the brochure, the patient-facing brochure translated into Spanish, but we have not actually tested that yet. We're actually about to do that in another study. But we did specifically get feedback on, for example, things like that we needed to make sure that the materials were felt representative to people from different races and ethnicities. And so in Align, we tried to make sure that we were doing that. And then we also, asked about, whether any phrases were, more or less resonant. And by and large, I mean, I would say the feedback we received was, pretty much that, that it was important to make sure that the materials were, offered in different languages and included pictures of, people said we want pictures of people who look like us. Not necessarily that we had to use different, the different things were important to people, but just that, make sure that everything is inclusive.
Thank you. And then Angela, you say you have a question about PCP prescribing versus specialists, cardiology or neurology meds. Do you want to elaborate on it?
Yeah, hi, my name's Angela, and I'm a dementia care provider at the memory clinic, but I'm also a geriatrician. So I'm often telling people to politely ask their cardiologist or their specialist to, can we please stop a medicine, and it's definitely, I mean, I definitely feel empowered to be like, yeah, we should stop this, but it's a little more tricky when I'm asking someone to de-prescribe a medicine that I didn't prescribe. Do you have suggestions about the art of that?
Yeah, no, that would be a great topic for a future study, is like the language to speak to, or the art of how to speak to specialists about de-prescribing. In Align, we found that having the clinical pharmacist sort of, so we designed this with the clinical pharmacist sort of being the intermediary, I guess. And so they actually, in many cases, reached out to the specialist. And that worked in the two healthcare systems where we piloted Align, because they're able to communicate easily with them through the EMR. But so I think that idea of that's another potential role for the clinical pharmacist, is that they can help facilitate those conversations.
Yeah, and I would say that what works for me, I mean, obviously just what works for me is just that communication. And I do a lot of like reaching out to the prescribing doc, and Epic makes it pretty easy, and even just old-fashioned faxing back and forth. But that doesn't scale up very well. And I'm a research doc, and I can do that on Fridays. But I mean, it doesn't scale up very well for a really busy neurologist. I can't imagine that they would do what I do on Fridays.
Yeah, I totally agree with that. And so, I think the pharmacist can help with scaling when that is, that's part of their role, to send these messages. But I also think, honestly, that like a separate intervention is going to be needed to try to, spread some of these, this education about de-prescribing to specialists, because I do think it is very hard to have the PCPs kind of be expected to do all of that communication.
And then, like Amy was asking if you have any data on differences in perceptions between persons with dementia's opinions about de-prescribing versus their care partners.
That's a really good question as well. I am thinking back to the qualitative research where we, often interviewed people, both the patient and the care partner. And I would say and we're actually about to do another study kind of looking at how often there may be misalignment in their goals related to de-prescribing. So I would say in these studies, it was more, the patients tended to have more advanced dementia, and the care partners had concerns both about behavioral symptoms. And so that's where that idea came from, that, you really have to understand their lived experience. So I remember one quote where a care partner said, like, you can tell us to stop Ativan, but like, we know what we go through on a daily basis. And we really need the Ativan. So, that was one important idea. And that came up actually in a line as well, that care partners they were actually more willing to stop preventive medicines than symptom medicines that were controlling symptoms such as pain or behavioral symptoms of dementia. And so the pharmacists were often, in order to align medications with goals, that sometimes meant keeping medicines that may be considered potentially inappropriate, but stopping other medicines to kind of make more room for those potentially. And so I guess, I don't know if that's exactly answering the question. I guess that's kind of, I would say, more to come from future research, because these studies tended, especially in Align, we were really focused on care partners. And so we tended to recruit patients with more advanced dementia. But I would say that was one interesting finding, is that the medication list at the end doesn't always look like what we as geriatricians going into a de-prescribing study thought it would look like, but it was more aligned with the care partners' goals.
Yeah, that's a good insight. And I guess, yeah, I would be interested too in this information about people who don't have as advanced dementia, because in clinical practice, we often see that the patient is saying, yeah, I want comfort, but the family might not be ready for letting go of more life-belonging things. So
yeah, and we actually have another study that we're hoping to start this year, really focused on those triadic interactions. So really trying to get at that more. And we also, going back to the previous question, are about to test the optimized materials in a clinic in Pennsylvania that has a much higher proportion of lower income and also Hispanic and Latinx patients. And so that'll give us more opportunity to also get at some of the, how these messages are received by people who primarily speak other languages or of different cultural backgrounds.
Okay. And then Elizabeth has a question about, how did you determine your sample size for the pilot?
For the Align pilot?
I believe so.
That's a good question. So we wanted to make sure that we had enough, I'm trying to think back here, that we had enough patients to hopefully, we're primarily focused on feasibility and acceptability, I guess, is the first thing I should say. We want to learn about the variability in the primary outcomes, the medication regimen complexity index, especially, so that we can try to plan the sample size for the future study. But we're not as concerned with the effect size in this study. And so we're not, so we didn't need a large sample size for that reason. So we were trying, it was sort of a mix of, having enough patients so that we could get information on variability, but also still, it's a 1-year pilot. And so making it feasible.
And then was there any training to the clinic staff and PCPs other than the tip sheet?
In Optimize, there was, so the PCPs received just a brief, like under 15-minute presentation at a regular staff meeting that was really just kind of giving them a heads up that we're going to be doing this study, and sort of very brief introduction to de-prescribing and to these materials that they would be getting. And then the PCPs, so that was the only training. And then they also received just in their schedule in Epic, they would receive a little note that your patient has received the optimized materials.
Okay. And then Gina was asking were there any assessments in either study about, and like either pilot, for the patient and patient support, assessments on health literacy?
Yeah, that's a great question. In Optimize, no. So Optimize was designed to be fully pragmatic. So no information was obtained from patients at all. It was just what we could obtain from the EMR. So all of the outcomes were from the EMR, and they were not actually, enrolled in the sense that they were just sent the materials ahead of a primary care visit, and it was left completely up to the patient and the family and the PCP whether they wanted to discuss the materials. So we did not assess health literacy in Optimize. In Align, we similarly, it was also, we did not assess health literacy in Align. In the study that we're just about to start, where we're testing the optimized materials in this clinic in Pennsylvania, we are actually going to be asking them about a health literacy screener.
Thank you. And then there's a couple of comments from Kay and Lauren, like both acknowledging that how great it is that the medalist doesn't, the point about medalist not necessarily reflecting what we thought it would be, and how important it is to really consider what the patients need and want. And sometimes we think it's not referring, but it may be that it is for them. So
yeah, that is, as I said, we just wrapped up the actual intervention. So we're still kind of looking at the data, but so far I would say that has surprised us. That it's in some ways we're learning, we sort of designed it as a de-prescribing intervention, but it's really about goal aligned de-prescribing and prescribing. And so not necessarily, not necessarily shrinking the medication count or the complexity of the regimen, but making it more goal aligned.
And then Elizabeth was asking, what do you see as the biggest potential threats to translation of the Align intervention?
So I think some of those are things that you all have asked about already. So, one thing is that we were, as I mentioned before, we were really fortunate to be able to do this in health systems that already had embedded clinical pharmacists who were, very trusted, and sort of that idea of the clinical pharmacist reaching out to the PCP or even to the specialist. As I mentioned, they reached out to neurologists in the study and cardiologists. And so that didn't shock any of the providers. They had a good rate of, responding back to them. And so I think, scaling that is going to be challenging. I do think that we have to think about issues like health literacy, and then finally training of the pharmacists. And then the other thing is that because we focused on the whole drug regimen, I think, we're finding that even for the clinical pharmacists, the idea was to take it off the plate of the PCP, and to kind of make it synergize with work that the pharmacists are already doing. But it does take a long time to do this intervention. So with indirect and direct time, it was taking like 2 hours per patient to review their med list, talk to them, come up with recommendations, communicate with the PCP or the specialist, and then get back to the patient. And they said that's not real. The pharmacist said that's not really out of line with how long it takes them to work with complex patients for other interventions, but I think scaling it does make it challenging. So we have to make sure we have the right focus on the right patient population, and I think also the right medications. So we're talking now about, whether we may not focus on the whole regimen, but maybe narrow it down a little bit.
Okay, thank you. And then what was the best way for the PharmD and PCP to communicate? Like I think you mentioned EMR. There's in the question also asking, was it a different tool, phone call, letters?
So this was designed to be done entirely through the EMR so that the pharmacist could be more centralized. So in the one clinic, the pharmacist was, she was actually present in the clinic, but still communicated through the EMR. But there was, I suppose, that possibility, and we're going to find out from her if that happened often, the possibility that she could just bump into a PCP. But in the KP system, it was 18 different clinics and one pharmacist, and she was centralized.
Thank you. Anyone has any more questions or comments? We are right at 9. So I think we're right at the end of the time. Okay, yeah, just like great research and talk. Thank you so much. We really
Thank you.
appreciate you being here.
Thank you so much for having me. And
then-
also for all of your fabulous questions. Those are going to be really helpful to me as I kind of plan the next steps. So I appreciate it.
a very engaged group, so that's good.
That was great. Thank you.
Yeah, thank you. And I think the talk was recorded, so it will probably be, I think Dan probably asked you already, but she'll of course check with you so that it can be uploaded at some point to the site and with the slides. Yeah.
Sounds good. Thank you so much.
Thank you again. We really,
All
really
right.
appreciate you coming. Bye.
Bye.